Ralph Edwards, the former director of the Uppsala Monitoring System Center. He has written on basically every topic imaginable on issues within pharmacology, as well as questions on risk and safety. He recently co-edited a volume, Pharmacovigilance, Critique and Ways Forward, which I just started reading recently, and it's actually it's quite thrilling, so I definitely recommend checking it out. So Ralph, take it away.
I was a bit late joining. My background, that's mostly relevant to this talk anyway, is first of all, I'm a retired professor in medicine. So I've been involved in clinical trials and all kinds of scientific work within the medical field. And then I ended up, as you heard, as director of the Uppsala Monitoring Center, which provides for WHO all of the practical monitoring of adverse effects of drugs. And it's led me into really the field of risk and benefit, which I think is critical to what we're talking about. It also has given me a very clear idea about how a good scientific study should be performed. And I want to go through briefly those things. And I start with evidence. If you don't have good evidence for what you're doing, and that evidence always comes from a particular context, which is important to understand, then it's very difficult right at the very beginning to talk about social responsibility. And of course, it's social responsibility to whom? It's all very well to develop new drugs, new vaccines, and so on. But what about the adverse effects of those? What are the people who are outside the norm? I mean, normally, the norm, we would expect a medicine to actually help someone. But what happens if it doesn't? How do we weigh that against the benefits? And can you do that, or how do you do it on a social scale? In that respect, I perhaps should tell you or remind you that adverse drug reactions are the 5th most common cause of death in the United States, and similarly in other countries. The kind of study that observational studies have been done in many countries. So the 5th most common cause of death puts it just ahead of deaths from all respiratory causes. And what do we know about adverse drug reactions? Do we do anything about it? And my answer is, it's all just a chance. People do some bits. The thalidomide disaster has been dealt with over and over again, debated over and over again, but there are many other adverse reactions that we still know very little about. So what is the responsible way of dealing with this? Now, my center, the Uppsala Monitoring Center, was monitoring reports of adverse effects globally. It's a database now that has something of the order of 40 million case reports of people who've been damaged by drugs. So it clearly is a big problem, but as soon as you say, well, okay, what's the evidence, really? These are just anecdotes, it isn't scientific evidence. But somebody has thought that there's a problem. how do we deal with a situation like that? And COVID is not dissimilar. We have little bits of information from all over the place, but how much of it is evidence, and evidence about what? I mean, one of the things that I keep on thinking about COVID is people say so many people have died of COVID, and the previous speaker mentioned this point that do we know whether they died from the disease or did they actually have COVID and die from something else? It's very unclear at the moment. So even in this situation, we're not so sure about evidence from the very beginning. And nobody seems to be bothered about that, which really is a big irritation to me. But so the evidence is a critical starting point. Exactly how was that evidence obtained? How can you compare Sweden for COVID, where they actually have recorded deaths of every person who has had the diagnosis COVID on them, but may have died of something else, compared with what happens in the UK, which I think is quite different. And certainly it's different from what happens in the US. So we really don't have that starting point. Then we, of course, have people who begin to use the evidence and assess it. Okay, well, what do? They go off and they make predictions on this evidence that I think I've suggested is not great. And we get lots of predictions about how many people are going to die, how many people will develop the disease. And when we talk about develop the disease, COVID, are we talking about mild COVID, serious COVID, COVID that takes people into intensive care, COVID that kills people? What are the medical interventions that are good and bad? There's all lots of information, bits of information around, but nobody seems to be putting it together. So I have a real problem with the current situation with COVID. I have seen this many times before as well, where, for example, one can have, say, 100 people reporting an adverse reaction to a drug, a serious adverse reaction to a drug from, say, 30 countries, okay? So there are very few cases within an individual country, but totally there are a lot of cases. But how do you get someone interested to look at those cases and try to do a scientific study? Why was it that those people had a problem and others don't? Was it, I mean, is the evidence faulty? Were they making it up? Nobody's bothered to investigate it. We have, sticking to vaccines, we published a paper on the odd outcomes from HPV vaccination. And we have thousands of people who have complained that after HPV, they weren't able to go to work, do anything. They were bedbound. and these are young people, of course, so work means, on the whole, go to school. And we have many stories of teenagers, young children, that have been like that. They haven't been able to attend school for months. And it's written down as a diagnosis of myalgic encephalitis. So were they? If they are, and we need to find out if they are, were they related to the vaccine, and what should be done about it? And interestingly enough, we did find that something like 80% of these people have antibodies to neurotransmitters after HPV, which is a higher rate much higher rate than you would find in a normal population. But there's no formal control study being done. So we still don't really know whether that is a mechanism that ought to be followed up. And it's been buried. Frankly, it's been buried. The work hasn't been done because it's so easy to say, well, myalgic encephalitis, this condition, it doesn't mean very much, but it damn well means a lot to those people who have it. I must go on, though. I think that one of our problems after talking about good evidence is transparency, and transparency in how people investigate that evidence. What have they done? What is the trial? What are the good things about the trial mechanism? What are the bad things? As the trial goes on, thinking about funding, does it need more funding? How do you decide it needs more funding? Is this just a waste of time? Or should we actually put more money into it? And I've, in my paper that I sent around, I suggested that there are ways that we should have to ensure that studies are good and they stay good during their operation. And transparency is the main thing. And I've suggested the so-called agile process is the way forward, where all of the players in the study, including the people who are representatives of the people who are likely to be affected, are present and able to make comments on the study as it unfolds, not wait till the end. And if it needs more money, they decide how to get that extra funding. My last point, I think, is that I'm not the only one. There's the so-called donut approach to considering trials and funding and socially responsible research, which we can discuss in the later on. But that asks that we not only think about funding for a piece of science and we say, okay, this looks good to do this short-term thing. We also need to think about what it might do long-term. And broadening the issue of socially responsible funding, using artificial intelligence, and even thinking about robots as policemen, as soldiers, which we're thinking about, robot diagnostic staff and care staff in hospitals. Do we really know what that might mean? Have we really thought it through? And my suggestion is no. My very last point is some colleagues and myself who belong to a group called Cause Health are very concerned about the way healthcare research is done. And most of it is done on a linear basis, where you have an idea and you do some investigations and you see whether animal experiments work. And if they work they seem to work, you see whether there's a problem with it in animals. Toxicological studies are done, and it's a linear process that takes a long time. It also involves a very few people. It's people from industry and people who are regulators. Are those the right people? Shouldn't it be a wider group? I mean, science as a whole works on, you have an idea, you publish it, and lots of people see it and start work on it. And the idea is tossed around and investigated, and some other people may benefit from it or not, as the case may be. But openness, transparency is a key thing which we don't have at the moment in healthcare research, and I think other research. And I will stop there, and I hope that there is some fruit for discussion later on.